Each week, I host 1 or 2 forums in the district on topics vital to your life. Here is a tape of one of those forums.
Today our discussion will be about stroke prevention and treatment, and I really hope you enjoy the talk. So as I mentioned, Winthrop is a New York State primary stroke center, and it's been designated since 2005. And I actually took this role on in the latter part of 2005, October 2005. So Winthrop's hospital stroke team consists of very qualified members. We have board-certified neurologists, neurosurgeons, radiologists. Our ED physicians are actively involved, as well as the nurses. We have a neurocritical care and stroke neurologist. We have interventional radiologists or specialists that deal with treating acute stroke, not only with clot buster medication, which we'll talk about, but also additional acute treatment measures in the early hours of stroke. We have neuro-ICU PAs, which are physician assistants and nurse practitioners, and myself as a nurse practitioner, I'm a first responder on the stroke team, and that what entails is anytime my beeper goes off and I'm on stroke coverage, I kind of have to drop everything and run because time equals brain, and you'll see what I mean by that. Experienced neuro-ICU nurses, certified neuroscience nurses. So now when we talk about CNRNs, certified neuroscience registered nurses, that's actually a certification that you take. So a lot of our nurses in the ICU are certified, and it's a really good accomplishment because it's one of the toughest nursing certifications in the country. Myself as a program coordinator, I'm also certified as well. You have to lead by example. So we are really happy about that. We're also a magnet hospital with nursing excellence. We recently received that designation as well. We have our own dedicated, what you call neurovascular tech, and what he does is helps do the sonogram of the neck, you know, other specified sonograms for neurology. We have our own case managers, social workers, our own physical therapists, occupational therapists, and speech-language pathology staff. So we really have multidisciplinary rounds daily, and then again in the afternoon, so it's really twice a day, and everyone gets involved in the care. We have 24-hour service. We have CAT scanners, not only in the CAT scan department, but also one directly across from the emergency room. So we have quick access to get imaging done when someone comes with an acute stroke. Our MRI department is available. Our ICU is 14 beds, as well as an additional 7 beds in the step-down. I think that says 6, but it's actually 7 in the step-down unit. So we're able to really care for these type of critical patients very closely. OR and trauma team available 24/7. Our neurointerventionalists to treat with other acute measures. Neurosurgery and hyperbaric treatment is another treatment that we use for acute stroke. So what is stroke or brain attack? So it's a medical emergency with an acute onset towards sudden symptoms. It's a lack of oxygen to the brain due to blockage or blood flow or hemorrhage. So you have a decreased blood flow into the brain, causing a neurological damage. So that damage area is called the infarct core, okay? So neurological deficits depend on which blood vessel is damaged and whether it's caused by blockage or a hemorrhage. So when someone first comes in, the first thing we want to do is get a CAT scan. If there's blood, we have to treat it a different way. If there's no blood, the symptoms are significant enough, we have to decide how we're going to treat and how quickly. So this is just really a diagram of the different blood supplies within the brain. You have the anterior circulation, the middle cerebral artery, and the posterior part of the brain. So depending on what your symptoms are, we're actually able to kind of figure out where in the brain are you having the deficits. So there's a correlation between your clinical presentation or your signs and symptoms, and then correlating that with imaging. So it's actually very fascinating. So depending on what the symptoms are, you can actually say, well, you know, it is going to be in the frontal lobe of the brain, or this is going to be in the occipital part of the brain. Okay, so certain areas of the brain, like frontal has executive function, occipital may have some vision, etc. So each area really gives you a good sense of where you think the stroke might be, and that's why I find neurology so fascinating. So the types of stroke include mostly ischemic and hemorrhagic, so about close to 80 to 88% is from a blockage. Then you have another percentage that's intracerebral hemorrhage that's caused by a leakage or a bleeding from the vessel into the brain tissue itself. And you have another subgroup called subarachnoid hemorrhage, where there's bleeding within the brain tissue in the subarachnoid space. And in that space is where the cerebral spinal fluid is the nutrient that kind of nourishes and keeps the brain healthy. And that is a separate entity when it comes to stroke. It happens in a different way than the intracerebral hemorrhage. So again, like I mentioned, ischemic stroke is caused by a blockage. You have a thrombus in that vessel, if you can see that. Now the area around the vessel, I don't know if you can see the word penumbra. So penumbra is that area of the brain. This is now, aside from the infarction or the infarct core. So once you have an infarct core, what that means is that area of the brain has already been compromised. So there's really nothing we can do about the infarct core. But what we're concerned about is the ischemic penumbra around the infarct core. That's what we're trying to save. So when you hear me talk about penumbra, it's trying to save that area of the brain that is salvageable. So what are the causes of ischemic stroke? Well, it begins with the development of fatty deposits. I'm sorry, this slide, I think it's cut off a little bit. Deposits that line the blood vessel wall. So the thrombus is a development of the clot at the fatty deposit. And an embolus is when it travels, the particles are too large to pass, so through a small vessel. So as I mentioned before, 80 to about 85, in some places you'll hear 88%, or thrombotic occlusion. So you have a damage to the vessel wall by atherosclerosis, or that plaque buildup from platelets and thrombus activation. And then you have the embolic subgroup within that, and that's when it comes from places like the heart, maybe after heart surgery, or some valvular disease in the heart. And then you can have particles that travel from like the carotid artery, which is a larger vessel. Hemorrhage is about 15 to 20%, and the causes really are uncontrolled high blood pressure, something called an AVM, arteriovenous malformation. And what that is a ball of arteries and veins that are not formed properly. So given the right circumstance, such as high blood pressure, over time it weakens it more and more and more until it actually bleeds into the brain. Okay? And then you have something called an aneurysm, which probably most of you may be familiar with or have heard of. Ballooning out of the vessel is already weak, and then when you're placed in a specific situation, such as straining, high blood pressure, or sometimes you have a genetic predisposition to aneurysm, then what you will see is that over time that aneurysm will ultimately burst. There are some cases where some aneurysms are not as likely to burst, but typically that's what causes subarachnoid hemorrhage, is the infiltration of blood products into the subarachnoid space, which nourishes the brain. Okay, so I did say what the two types are. You have intracerebral and subarachnoid. But this is what you would see on CAT scan. So the image on your left is that white area is blood. So that's what blood looks like on a CAT scan. To the right, I guess it's when you go to anatomy and physiology and you go into the lab and you dissect the brain, that's what that area would look like, that dark, thick, coagulated blood. And the diagram at the bottom is just a drawing. So now the causes of hemorrhagic stroke, like I said, occurs when there's a weakened vessel that ruptures. It's called a hypertensive hemorrhage. And there are areas of the brain that when we look at the hemorrhage, we know most of the time if it's hypertensive, like if it's deep into the brain, we know that it's hypertensive. There are issues or certain conditions where you have a hypertensive bleed or you have a bleed into the brain, but you're not sure if it's from high blood pressure or is it from an underlying mass. So blood can obscure your ability to tell if it's just a simple bleeding from high blood pressure or if it's from a mass, especially if it's not in the traditional areas of the brain where you would see bleeding from high blood pressure. We talked about the aneurysms that cause a ballooning of a weakened region in the vessel and then ultimately ruptures, and we talked about AVMs. So this is, again, is a picture of what on the left you would see with subarachnoid hemorrhage, and on the right you see areas within the brain, the little spaces where you see the blood has leaked in there. And blood is very caustic to the brain. So when someone has a subarachnoid hemorrhage, they're very likely to be prone to seizures, spasming of the vessels because the vessels are so irritated. So there's a lot of things to look for and complications to try to avoid when someone has a subarachnoid hemorrhage. But this is what it looks like on CAT scan, the image on the right. So now there's about 800,000 strokes a year. 75% are first strokes. Almost 5 million Americans are stroke survivors. So stroke used to be the third leading cause of death, and just death in the United States, then the fourth leading, and now it's the fifth leading. So when you go from first, second, third, fourth, fifth, we are doing something right because it's not, it's no longer 4, it's now 5. So we'll talk about what we're doing right, okay? It still remains the leading cause of serious long-term disability. The costs in the United States exceed $40 billion a year, and it is expected that the prevalence to increase by 25% between 2010 and 2030. But stroke is preventable. That is the good news. So whatever we've been doing, just have to continue doing that and even up the ante a bit. Risk factors for stroke that unfortunately we cannot change, that are not modifiable. So a prior history of stroke, we cannot do anything about that. Your age, your race, your gender, or a family history of stroke. But there are things that we can modify. So let's talk about the modifiable risks. We have hypertension or high blood pressure, diabetes, high cholesterol, irregular heart rhythm or abnormality, carotid artery disease, smoking, alcohol, and clotting dysfunction. So the top ones are really high blood pressure, diabetes, cholesterol, and the irregular heart rhythm. Have you guys heard of atrial fibrillation? Okay, so that history in and of itself puts you at even higher risk of recurrent stroke. So whenever someone is found to have atrial fibrillation, let's say they also have high blood pressure or high cholesterol, but they specifically have atrial fibrillation, there's a different medication or treatment, a stronger blood thinner to treat stroke. So we have to take that into consideration. So we just have to be mindful that we go through that entire checklist to make sure we've tried to figure out what the cause of the stroke is. Clotting dysfunctions, typically we find that at younger ages, but sometimes in older people. Younger people, if they come in with a stroke or what is a TIA, and I'll talk about that, and there's no other risk factors like the ones on this list, then we have to start to think about what else could put a young person, otherwise healthy, at risk for stroke. So what's not on here is things like if they have You know, if they have neck manipulation and they injure their neck vessel, because sometimes that can happen, or someone has a motor vehicle accident and they injure what you call the vertebral artery that supplies the back part of the brain, you can actually get a stroke that way. It happens. Also, if someone has something called a PFO, which is a patent foramen ovale. So that is a small hole in the heart that closes shortly after birth, and there's a percentage of the population where it doesn't completely close and they do fine. But then there's another percentage where it does cause symptoms, you know, and we have testing that we can do to see if there's a transmission of clots or emboli from that hole in the heart to the brain. And we have a very simple test that we do for that to try to mimic, you know, a clot passing through the heart into the brain. And also women that are, you know, pregnant, or people that have cancer or some other condition that puts them at risk for being hypercoagulable or high risk of clotting. We have to look at that subgroup as well, okay, and try to figure out how we can control that. So the signs of stroke, and there are 5 major ones. So you have numbness, weakness of the face, arm, or leg, usually on one side. And what's missing in a lot of these, I'm going to stress the importance, is sudden, okay? Stroke is a sudden attack on the brain, okay? So sudden numbness or weakness on the face, arm, and or leg, usually on one side, okay? Sudden trouble seeing or double vision, seeing flashes of light, kaleidoscope, whatever that is, or your vision goes black. That is not normal, okay? Even though the eyes can see, but the images that come through the eye has to be processed in the brain, okay? So the brain helps in us being able to see and recognize what we see, okay? Difficulty speaking or understanding spoken word. Now, when you ask, you know, a patient to, you know, you ask them open-ended questions to see if there's trouble speaking. Slow speech, mixing up your words, not making any sense. Slurred speech are all speech language abnormalities. Or if someone all of a sudden cannot read, you know, the newspaper or cannot write, that's a language problem. Okay. Sudden, which is missing from here, but sudden loss of balance or coordination, difficulty standing or walking. So if you see somebody continuing to lean to one side, bumping into the wall, that means something is happening in the brain, okay? Just for your reference, right side of the brain controls left side of the body and vice versa. So if something's happening on one side of the body, think it could be coming from the brain, medical emergency, okay? Sudden severe headache of unknown cause. This is usually what we call as clinicians the thunderclap headache. Like, it's literally like a pop. And it also can come with altered consciousness. You know, you may lose consciousness. Some people may have, you know, neck pain all of a sudden, nausea, vomiting. So again, this is a medical emergency. Those people tend to deteriorate very quickly because a lot of times it's of a bleeding nature, like a subarachnoid hemorrhage or aneurysm that pops, okay? Medical emergency. So now let's talk about the Cincinnati pre-hospital stroke scale. So this is a scale that clinicians use as well as EMS to quickly identify someone who may be having a stroke so that you can move quickly, okay? So it used to identify the 3 major signs of stroke. And we have something called the FAST algorithms. I want you to write this down, F-A-S-T. F for face, crooked on one side. A for arm or leg weakness. S for speech or language difficulty. And the T in FAST is time equals brain, and to call 911 right away, okay? So the face, arm or leg, speech, those are the 3 major stroke symptoms. So if you have one of those symptoms, there's a 72% chance that it could be a stroke, all right? All three, 85%. Now, there are certain conditions that mimic stroke, and we get that, but with stroke, because of the fact that it could be a medical emergency and there's aggressive treatments that we have to do quickly, you don't want to take the chance to think it's something else. Like you wake up and then your arm is dead. It could be a stroke, it could be something else, but until you come and get evaluated, you may put yourself out of the treatment window, and we're left now with just trying to manage your deficits at that point, okay? So you want to allow yourself the best possible chance, or your family member the best possible chance, by calling 911 to get to the hospital right away, okay? So this is how you're going to perform the, you're going to ask the person to smile, okay? So that looks pretty symmetrical, would you say? Yeah? Okay. What's wrong with that? Which side looks like it's droopy? All right, his right to the on our left on the picture. Very good, very good. And also what you'll see is that the tongue will be deviated, like because of the fact that there's the weakness. Let's say you have good strength on one side and weakness on the other, so now the tongue cannot stay towards the center, so it deviates down, and that the tongue also shows you that there's weakness, okay? You can have some slurred speech with that as well. So now when we talk about arm drift, we're going to have the patient close their eyes and hold their arms out in front of them. Both arms should move the same way, or both arms do not move at all. So let me show you what that looks like. Okay, so that one seems pretty normal. But what about this one? See the difference?
Yes.
Okay. And what you do is you ask them to hold their arms up for 10 seconds. Okay? And then you'll see a slow drift downward. That's a subtle sign of weakness. Okay? And I want you to pay attention to something else also. Remember how the right side of his face was weak? He had a facial droop, and also his tongue was weak, and it was hanging on that right side. But what side is his weakness on the arm? Also on the right. So what does that tell you? That something is happening in the left side of the brain, okay? So now we also check a person's leg. I mean, some people usually don't. They just see the arm and they call 911. But when we're examining patients, we'll ask them to raise their leg up for 5 seconds and look also for that subtle drift down as a sign of weakness. Okay. So speech, you want to ask some open-ended questions. Look to see if they're mixing up words or terms. There's something called a word salad. So somebody, you know, you'll ask them, what is your name? And then you're like, okay. It's like they understand, but they can't get it out. It just is like a mishmash of words. So we call that a word salad. So you can ask them to repeat a sentence. They may not be able to do that. You can also make sure to ask open-ended questions, okay? What is your name? What time is it? Are you, not yes/no questions. Are you okay? Yeah, you know, a lot of people just nod, you know, because they don't understand what's going on. So open-ended questions. So time is brain and the need for urgency. So 1.9 million nerve cells die and 14 billion synapses are lost, which is the connections between the brain cells, per minute in an acute ischemic stroke. So that's a lot of cells being compromised, okay? Because the brain does not regenerate. So once an area of the brain has been, you know, infarcted is what we call it, then that's that. And the brain can try to recircuit itself and to work around that damage, and that's called neuroplasticity. So that's a good thing, is that if an area of the brain is damaged and you are, depending on how healthy your brain is, pre-existing conditions, your age, how big the stroke or the infarct was, the brain can kind of go around and use different pathways to compensate for some of the deficits. So some people can recover completely, some can recover partially, some may not be able to recover after a devastating stroke. So it all depends. Everyone is different. Pea-sized portion of the tissue dies every 12 minutes after treatment, 12 minutes that treatment is delayed. So when I say time equals brain, I literally mean time equals brain, okay? The brain ages 3.6 years each hour without treatment. So the average time of symptom onset to the ED is about 17 to 22 hours. 42% of people over the age of 50 do not recognize signs and symptoms of stroke, but we've come a ways. 17% of people over 50 can't name a single stroke symptom. So if you haven't been able to do that before, I hope that after this talk you're able to do that, okay?
Excuse me,
yes.
I know you said before, what is ED again?
Emergency department. Or ER, ED, emergency room, emergency department. So if I say a term, because I'm pretty, aware that as I'm saying medical terms to try to describe it. So if I say something you don't understand, you can stop me, okay? And then I'll certainly explain it. So ED is emergency department. And only 20 to 25% arrive within 3 hours. So the reasons for delay is that people just don't recognize them. They're in denial. I woke up, I must have pinched a nerve or something. I can't move my arm. They call their primary care doctor first. And then by the time, because the doctor's office is not open, because all of a sudden you wake up and you find that you're having these deficits and it's 6 a.m. No one's at the office. The on-call doctor, you're waiting for them to call back and time is ticking away. Or you decide to drive yourself. Now, that may sound a little odd because if you're driving yourself to the hospital, you think, well, I'm going to get there right away. But the studies have shown that when you come in via the ambulance with stroke symptoms, you get triaged much faster. And EMS recognizes these symptoms and will pre-notify the hospital en route to say that we are on our way. And it's actually a law now that EMS has to pre-notify. Department of Health wants them to pre-notify the hospital. So the stroke team is actually waiting there for that patient to arrive. And difficulty in establishing the time of onset. So I haven't talked about the time of onset for acute treatment for stroke. But let's say you wake up at 6 a.m. So we'll go back to the 6 a.m. thing, and you can't move your arm, and your face is crooked on that side as well. And they ask you, well, what time did this start? What's your answer? It's not a trick question. You woke up at 6 a.m., right? 6 a.m., okay? And then they ask you, well, when did you last feel normal? When were you last normal? So what would be your answer? Just anybody, like.
I went to bed.
Okay, what time did you go to bed?
8 o'clock.
8 o'clock, good, okay. Did you wake up at any time between 8 o'clock and 6 a.m.?
Yes.
What time?
11 o'clock.
11 p.m.
Right.
Okay. And at that time, were you okay?
Yes.
Okay. Did you walk to the bathroom? Your arm wasn't weak. You happened to look in the mirror because, even if you're sleeping, you always want to look at yourself. Okay, so you were fine at that time. Okay, so at 11 p.m. Okay, so the questions that we're trying to, the answers that we're trying to elicit is, when was the last known well? So just because you went to bed at 8 p.m. doesn't mean that's your last known well. So when we ask you all these questions, be patient with us. I know it's a very difficult time. It's very stressful, but we're trying to figure out what time window we have to work with and if you meet the criteria for us to treat you within that time window. Okay? And it's very important that we get it right because if we treat you outside of that window, guess what? You're at risk for bleeding into that area of the brain. So it's very important, very strict criteria. So you went to bed at 8, you woke up at 11 at some point to use the restroom, and then the next time you woke up was 6 a.m. Okay, so at least we've kind of figured out now that this is the time window that we're working with. Okay. What do I do if I notice these symptoms? Call 911. It's that simple. Call 911. Every moment that goes by, you lose brain cells. So like I said, EMS is trained, okay? They know to call the stroke center ahead of time. Winthrop is a designated stroke center, and they're responsible for pre-notifying us. And if we meet the time window criteria, then the stroke team is paged by the hospital for us to be there. So whenever I'm covering, once I see we have our little, you know, things that we have a way that we have the operator page. So they say EMS stroke page en route. ETA, or estimated time arrival, they may say 10 minutes. Okay, so I know that if I see that I have to hurry up and be downstairs and waiting for that patient to get there. So in the meantime, we start activating our team. Okay, so our pager, not only does the stroke team get it, but radiology gets it too. The radiology techs already know that there's a stroke patient en route and to try to get prepared. So the nurse that receives the call now knows to alert an ED physician that we have an acute stroke coming in. Let's get prepared. Okay? So a couple of triggers, a couple of different things, at least how our system works at Winthrop. So the goal is to transfer potential stroke patients to the nearest stroke center, the fastest and quickest center. Pre-notify the hospital, possible stroke en route, and provide the information that I spoke to you about. What time did the symptoms start? When was the last known well? What were the actual symptoms? Finger stick or blood sugar. Any reason why you think we would want a blood sugar level? Exactly, hypoglycemia. So remember when I said that there's certain conditions that mimic or can look like stroke? So someone whose blood sugar is too low can have trouble speaking or can all of a sudden be weak on one side. Someone who has a history of seizures, when someone has, what happens is an abnormal electrical activity in one part of the brain, so that just like interferes with the entire electrical activity of the brain. So someone may be left after their seizure with the inability to speak or weakness on one side, and it correlates with that area of the brain that was affected, okay? That's just to name two things that could look like stroke. There are others out there, okay? Medications, it's good to know that if you're on a blood thinner, because if we treat you with the clot buster that I'm gonna talk to you about, and you're on blood thinning medication, it may complicate matters more. So there are certain criteria for that. And also EMS should provide us with a family contact number. So whenever you call EMS, it's always good practice to provide, if you're going to the hospital and you're not going to be in the ambulance with your family member or loved one, give them your cell phone number, because you're not going to be at home. So if we need to reach a family member to get more information and you're not home, it's just delaying us trying to make a decision of how quickly to treat you and what other information we need to make that decision. So provide the cell phone number if you're not going to be or no one's going to be home. Okay, then we can call you en route. Okay. So there's quite a few stroke centers in our area. As you know, Winthrop is one of them. So now let's talk about this TPA I've been, mentioning, tissue plasminogen activator. So it's a very strong clot buster to treat ischemic stroke, and I highlighted ischemic stroke because remember there's also hemorrhagic stroke. So if we give someone that has a hemorrhagic stroke a blood thinner, they're going to bleed more, and that could be devastating. Okay, must be given within 3 hours of really the last known well. So now when I talk about this 3-hour window, this is FDA approved. So when you come to the hospital for whatever condition you come into, there's something called a standard treatment of care, okay? Usually they give you all this paperwork to sign, and pretty much it's standard care. Just like if they give you an IV fluids to hydrate you, TPA is also standard treatment. It doesn't require, signature or approval. Just as long as there's a conversation with the family and the patient and that they want to proceed with TPA, okay? So let's say, for example, okay, you are at the supermarket and it's 12:30 in the afternoon, and you've paid for your groceries at the counter, and you said to the checkout lady, "Thank you very much. Have a good afternoon. I'll see you next week." And then as you're starting to finish your sentence, you start slurring your words, and all of a sudden, the checkout lady noticed that you have facial droop. Okay? What time is the onset of the symptoms? You're at the checkout counter at 12:30. Exactly. When was the last known well? Exactly. It's the exact same time because it was witnessed by someone. So let's say you cannot give your medical information, and let's say you're a savvy person. You carry your in your little wallet, you have your list of your medications and your medical conditions, and you get to the hospital, and Kathy, myself, who's the first responder on the stroke team, sees your wallet, looks in it, and finds all this information. I have no family member to speak to. Okay, someone at the supermarket saw when you actually started having your symptoms. We can treat you. We don't need to ask you anything else if you're not able to communicate to us, okay, because you have speech problems, you have something called aphasia, which is a language speech problem. We can use that documentation and the witnesses to treat you because we know we have the time of onset. Okay, so there's a lot of different ways that we can treat people even if they're not able to speak for themselves. Okay, now there's also a 3 to 4.5 hour window to treat stroke. Now that requires FDA, that does not have FDA approval. That's the Food and Drug Administration, by the way, if I didn't tell you what that means. Food and Drug Administration. So 3-hour window, standard treatment of care, it's FDA approved. 3 to 4.5 hour window, not so fast. We have to get consent, signed consent from a family member if the patient is able to communicate that to us, okay? Again, you know, additional things that we have to look at aside from what we have for the 3-hour window. So if you're age 80 or greater, you fall out of this 3 to 4.5 hour window. Okay. If you're on a blood thinner, if you're greater than age 80, you fall out of that 3 to 4.5 hour window.
Within the 3 hours.
Well, within the 3 hours, age plays no part in it, okay? But when we're talking about someone who comes in and they're in the 3 to 4.5, when I say 3 to 4.5 hour window, I mean 3 to 4.5 hours from the last known well, okay? So your last known well was 6 a.m. and you arrive now at, 9:15, okay? 6 a.m. was your last known well. 9:15. You are 82 years old, you're excluded from treatment within that 3 to 4.5 hour window, okay, because the risk of bleeding and complications increases, okay? Also, if you've had a stroke, a prior history of stroke and diabetes, that excludes you. And there's a couple of other things. Blood thinner, no matter what blood thinner it is, no matter, what your level is, because there's a cutoff for example, Coumadin, which is a blood thinner, you're excluded, okay? Does that make sense?
Excluded from the 3 to 4.5 hours?
Right. Yes, excluded from the 3 to 4.5 hour window, yes.
So let me sort of rephrase that. What you're saying is if you're over 80 and you get there after 3 hours, you cannot get TPA.
That is correct.
Period.
Well, you fall out of the guidelines. However, if you choose to give us consent to treat, we have other tests that we do, not only the CAT scan, that simple brain imaging test that we do. We have something called a CAT scan angiogram, and the angiogram really gets a good look at the vessels. So if we're not sure, let's say you come and you're at that fine line, maybe 3 hours, maybe 3.5, we're not really sure, and you're a stellar 85-year-old, you're driving, you're running, that sort of thing, and you and your family decide you want the TPA, that would be a consent, okay? So it really depends. But typically, we don't treat outside of those parameters. Okay, I think I talked about this ischemic penumbra already. So it's area around the infarct core that we want to salvage, and that's what TPA helps us to do, to salvage that ischemic penumbra. So now I talked about the 0 to 3 hours. I talked about the 3 to 4.5. Now what if you're beyond that? Okay, so when we do a CAT scan, we look for a couple of things. We look for whether there's blood. So let's say there's no blood on your CAT scan, and you come in within the 3 hours, except one problem. You are on Coumadin, which is a very strong blood thinner, and your blood levels are too high. Okay, now on the CAT scan, we clearly see the vessel, and we see what we call a dense MCA sign, or a clot sitting right in the vessel. We can see it a lot, sometimes we can see it. So now you're in the 3-hour window. We can't give you another blood thinner, which is, you know, TPA, on top of the blood thinner you're already taking because your levels are too high. How do we get that clot out? Well, guess what? We have something called intra-arterial TPA. So intra-arterial TPA is taking that blood thinner I talked about, going to special procedures. Now, you know when you have a cardiac cath, they go through the groin artery and they go up to the heart to look to see what's going on. So now this is a cerebral cath, or a cerebral angiogram. That's another name for it. So what they do is they thread that all the way up to the brain vessel, right where the clot is, and squirt the TPA right in there. So it's local as opposed to systemic, so that you don't bleed into other areas of your body, like your gut, you know, or more into your brain, okay? So it doesn't stop at just the IV TPA. You have intra-arterial TPA. Now, okay, so now the other thing is that you have a big clot sitting there. We see it on the CAT scan. We don't think that the intra-arterial TPA is going to be enough. We think you need something even more than that. Well, guess what? We have something called thrombectomy, or mechanical clot retrieval. So different types of companies use different things, you know, to pull the clot out. So you can feasibly get the intra-arterial TPA, and then they have like the rotor-rooter where they pull the clot out, or suction mechanism where they pull the clot out. Okay, so it doesn't just stop at IV TPA. All right, there are time windows for the intra-arterial TPA up to 6 hours of the last known well, and you have the clot retrieval up to 8 hours. So that's what it's approved for. So now, just to let you know, you come in within the 3-hour window, you don't have a blood clotting issue, you are not on a blood thinner, we see the big clot sitting there, you get the IV TPA, but we know the clot is so big that the IV TPA is not going to be enough. You can feasibly get IV TPA, intra-arterial TPA, and clot retrieval. So if you come in quickly and you meet all those criteria, you can actually have the best possible result if you need to get all three. Okay? So hence, get to the hospital right away. Recognize stroke symptoms. So again, it's that time, that 3-hour window. And what you need to know beforehand. So we typically like to know, obviously, the time of onset or the last known well. We look to see it at the size of the stroke. So you come in, you're within the window, but we already see stroke on the CAT scan. That means, you know what, it's probably more than the 3 hours. You probably just didn't notice, like what we call wake-up strokes. You wake up in the middle of the night and you notice your symptoms. And if we already see your well-defined stroke on the CAT scan, you're excluded, okay? And if you still come in within that time window, but we see the stroke and it's in a huge area of the brain, if we give you TPA, you're actually at higher risk of bleeding because there's so much tissue that already has been affected that we may actually complicate your condition even more by giving you TPA. There's a lot of different nuances when it comes to stroke and how we're going to treat. Everyone that comes in is not the same, okay? And also getting your blood pressure under control if we need to at the time of TPA. Now, the brain is smart, and I say that very loosely, because when there's an event in the brain where there's a blockage of blood supply or oxygen to the brain, the body actually raises the blood pressure intentionally to get better flow to that area that's being affected. So it's not uncommon that someone comes in with a stroke and their blood pressure is very high. We typically don't treat that blood pressure unless we need to get it to the level that we need to give TPA. So if it's too high, we have to kind of bring it down so that you're not at risk for bleeding during the TPA administration. Okay. So the people that can administer TPA, the neurologist or the neurosurgeon, the ED physician, and the ICU attending. Now, in our hospital, we have a dedicated stroke team. Depending on what your hospital infrastructure is, you know, some hospitals, if they're smaller, that ER team, that ER doctor is the stroke team. At Winthrop, we have a dedicated team. So, you know, of course, in conjunction with my attending, if my attending is en route, let's say it's like, you know, 7-something in the morning and the doctor happens to be en route, and then my stroke attending has spoken to the radiologist, the ED attending, and I'm there, and we've gone through the whole inclusion-exclusion criteria checklist to treat or not to treat, and you meet the criteria to treat, we would initiate the bolus or the initial medication and then do the infusion. So the initial bolus is about 10%. And then the rest is given over an hour. So that's how it's done. It goes in very quickly. So now, just because you get TPA doesn't mean that you're going to be cured. So I just want to make that very clear. We never know how well you're going to do, but we know without the treatment, we're just left waiting and wondering and hoping that you'll improve. Okay. So how do we prevent it? Well, we use antiplatelet or antiplatelet medications such as aspirin, because remember, stroke is caused by a clot. So that clot is usually formed by platelets. Okay, so an antiplatelet medication like aspirin is what we use to try to prevent stroke. There are other medications out there. You probably have heard of them, clopidogrel, which is Plavix, Agranox, which is a combination of aspirin and another medication called dipyridamole, which helps keep the vessels open. So there's a couple of different things, but the gold standard is really aspirin, unless you have a condition that warrants us to use something else. Blood thinners like warfarin, also known as Coumadin. You'll probably hear the newer ones, which are the novel oral anticoagulants, such as Eliquis, Xarelto, Rivaroxaban. You probably have heard some of those, and some stars are actually talk about it. Okay, managing your blood pressure. So obviously, when you first have a stroke, we want your blood pressure a little bit higher, because if we drop your blood pressure too fast, too quickly, you're actually putting yourself at risk to actually making your stroke worse or making it larger. Okay. Cholesterol lowering medications. Cholesterol helps to promote plaque, so we want to get your cholesterol under control. Even if your whole lipid panel that has 4 parts. So you have the total cholesterol, you have the HDL, and I remember H for healthy cholesterol, and LDL, L for lousy, because you know when you're in school you have all these things to remember. You have to find ways to remember things, right? So H for healthy, HDL, and LDL is a lousy.
The time is now 7:30. The computers will be shutting down at 7:45. The library will be closing at 8 o'clock. Please make your final selections and bring them to the circulation desk. Thank you.
Okay, so the library says we have to shut down soon. So we're at the home stretch, and I hope I'm not talking too much and that you're enjoying this. So even if you have a normal lipid panel, that we still would put you on a cholesterol-lowering medication, specifically the statin group. You probably have heard of atorvastatin, simvastatin. All these medications they have an anti-inflammatory effect, so they keep the vessel open and allow better flow in conjunction with or along with things like aspirin or Plavix, etc. Okay. And treatment of other conditions. So if you're diabetic, you're more prone to forming clots. You want to get your blood sugar under control. Here are the antiplatelets I talked about: aspirin, clopidogrel, aspirin dipyridamole combination, which is also known as Agranox. The blood thinners, as I mentioned. And then we have the antihypertensives for blood pressure. We have certain drug classes that work very well. The ACE inhibitors, and then we have other things, beta blockers, if you've heard of beta blockers that protects your heart. A lot of cardiologists use that stuff. And then other classes, calcium channel blockers and diuretics or water pills. Sometimes some people, just a simple water pill will help keep their pressure down. Okay. Here are the cholesterol medicines I talked about. Diabetes management, also obesity. So obesity puts you at risk for stroke as well, because if you think about it, when we talk about heart disease and stroke, basically if you're not eating healthy and you're overweight, that really puts a strain on the body. So staying healthy, keeping your weight under control is very important. I know all primary care providers stress the importance of staying active. Even if it's stretching or walking, you know, being stagnant doesn't help. And depression is a possible risk after stroke, because sometimes there's a change in the way your brain processes and you could have depression. So in our hospital, we kind of look for that early on, and if we see that that could be an issue, especially if you have pre-existing, depression, or you have a large depression family history, then we want to consider that. Okay. Smoking is a risk factor, as I mentioned earlier, so you want to stop smoking. Anytime you tell somebody to stop doing something, they want to do it more, sadly. But really, seriously, once you've had a stroke, you really want to consider quitting. And there's a lot of medications and treatments out there to help you stop, okay? Great diet, exercise, stress management. So when somebody says, I have a high-powered, stressful job and that's why I had a stroke, I mean, it may have some contributing factor in raising maybe your blood pressure or other things, but it's not a direct cause of stroke, because we all have stresses in our lives. But the risks that I talked about are the ones that we look for, okay? And moderate alcohol consumption, we usually say just to avoid alcohol, but 1 drink for a woman, 2 drinks for a man. Anything beyond that, you're at risk for stroke, okay? And life after stroke, we have rehab. So when you leave the hospital and you still have some weakness or trouble with your words, you're going to go to rehab to get you back on your feet. Support groups and community resources, whether it's home care, social work, financial health management, etc. So Winthrop does have a stroke support group, which meets the 3rd Wednesday of the month. Our next meeting is actually tomorrow, Wednesday. It always meets from 10 to 11:30, and I conduct that meeting along with my colleague Karen Antaki. She's also a nurse practitioner in the program. She's also a first responder. She's also CNRN certified, okay, as well as Lucia Disperito, who's our social worker. So if you ever have any other issues and you need further, someone to speak to or referrals in the community, Lucia is fantastic. As far as community things, like you'll see, obviously this is a community event, so I love to have talks. We also have, required by Department of Health as a stroke center, a stroke awareness program that we do every May. May is Stroke Awareness Month, so our last one was on May 5th of this year. It's always very well attended. We have sometimes upwards of 90+ people there. So we really have a good turnout. A lot of tables and different people to go talk to and different resources throughout the community. So now American Stroke Association has a program called Get With the Guidelines Stroke Program, and that's sponsored, and the goal is to really keep quality stroke care, to monitor quality stroke care within a hospital and with our neighboring hospitals. So what we do is we share our ideas, we share our obstacles, our best practices, and so that we can see how can we improve stroke care. So we have our champions, like our stroke attendings, the emergency room, radiology department, so all the different entities that help us to take care of stroke patients. So Winthrop, so depending on how well we do, we are awarded, achievement awards every year. So we have the bronze, the silver, the gold, sustained gold, and even Target Stroke Honor Roll. So Winthrop has been able to actually get award pretty much every single year, including this past February at the International Stroke Conference, which I pretty much have attended every year except for maybe 2 years in the last 10. So I'm very passionate about it, and I really am like, you know, the stroke police, so to speak, at the hospital. So everyone knows that when Kathy's around, oh God, Kathy, okay, where's the stroke? So everyone's on board, okay? So Target Stroke Honor Roll really looks at treating patients within that golden 60 minutes. So when someone comes into the hospital, we have 60 minutes to treat them or better. And if you treat people in 45 minutes, you get an additional award from Get With The Guidelines, okay? So it's very important that we keep this going. So this is the award we just received at the International Stroke Conference in February. So as you can see, it's Target Stroke Honor Roll Gold Plus. So we're actually shooting for now Honor Roll Elite. So we have work to do. And we've gotten some other awards as well. You know, we are part of a Coverdale registry, and it's a collaboration between neighboring hospitals about best practices. And on a quarterly basis, we have an area that we want to work on. Okay. And then also 5-star recipient, recognition of excellence in quality. So, you know, we're really working hard, and myself and the entire stroke team, we really enjoy what we do.